Okay.
All right. All right, we'll go ahead and get started here. First of all, I've been asked to talk to you guys a little bit about drug exchange. Now, first of all, I'll just kind of touch base on today what St. Francis is doing or kind of review that. But just so you know, I am putting a PowerPoint presentation together along with North Shore hospitals, because I know you go to North Shore hospitals also, and I know it's been very confusing and very frustrating to you trying to get your meds exchange when you are on a call or if you withdraw resuscitative efforts in the field. So if you will bear with me on that whole point, next month we're doing CE the first 3 Fridays, and so I'll have about a 20-minute presentation. I've got the sheets, what you have to do to help make it a little bit easier. Unfortunately, there's nothing I can do. When the FDA puts out a new law, that it is what it is. So, but at least hopefully we can clear up any confusion that you might be having. So, as far as St. Francis is concerned, this is the way it should be. And if there's any confusion, obviously if it's daytime hours, march yourself up to our EMS office. One of us will come down and we'll help you out as best as we can. They put a new Pyxis in. Let's start with that. And you have to do certain overrides. Unfortunately, as of the other day, you could not override aspirin or they could not override Zofran because they don't consider those emergency medications. But they forgot about you guys and needing those. So the pharmacy, when I talked to Jeff Murphy, just so you know, he was the manager of the ED. He is now the director over cardiac cath, EMS, and the ED. And so when I talked to him after I got a call from Chief regarding this, he was going to have pharmacy go down and do an override right away so that there was not going to be a delay for you guys. So if you go ahead and you bring a patient in to the hospital, you can get your medications restocked right off the bat. No questions asked. If you go ahead and you have a cardiac arrest and you withdraw resuscitative efforts in the field, you can come in, you can go to our pharmacist. Everybody know where the pharmacy is? It's on the back side of the ED. And you need a PCR and they will give you all the medications, okay? If you are being told anything else, the nurse just looks at you and says, you know what? She doesn't have time for you, and she's like, go to the pharmacy and get your meds. That's wrong. Let us know. Let your shift commander, battalion shift, whoever know, have them call us in the EMS office, and then we will go down and take care of it for you. Because we do not want you guys hung up in our ER for 15, 20 minutes, a half hour waiting for medications. You guys got to get back on the streets. So please let us know. We will do whatever we can to work with you guys. And then as far as the North Shore hospitals, I will have something starting next week on the Fridays going through how you need to do that, just in case there's any other questions. Yes, sir?
Yeah, so you said we need a PCR to get it. We went there the other day on a full rest, and they said you only need that for NARS, not for like epi. So they said we could go there, we not.
You got lucky. That's good.
No, that's what the pharmacist said directly to us.
Oh, perfect. You know what, if they're going to go. Jeff had just written down that if you don't bring a patient in but you need an exchange, then we require a PCR. And maybe if they're only going to do NARCs, that's fine.
That's what she said, only for NARS.
All right, perfect. It's these little things that
Also,
trying to get everything.
Just to get there and back, you can't get through the door. So just if someone was able to, I don't know if they are available at the receptionist desk. Like
I wonder if we can't get you guys just a generic badge that
once
we
you
can
get through, and then the nurse is busy because they gotta go.
And then you have to walk all the way around.
Well, yeah, it's just to get back into where your partner is. And
Let me see, because I know at other hospitals I've worked with, getting through the doors and into Pyxis systems and the supply cabinets, we've always made a generic badge so that people could get through the doors. Maybe we could take that and hang that up at the nurse's station. You walk through, you get your drugs, you walk through, and then you hang it up on your way back out. Let me see if I can look to see if that might work for you, okay? I know it's worked at other places I've worked. Let me give it a shot here and see if I can't sway that. Anybody have any questions regarding St. Francis meds? We want to make this as easy as possible. Unfortunately, the federal government always likes to screw that up. but we'll do our best what we can to work with you. And again, any problems, notify your shift commander immediately, especially if it's in the daytime, call us in the office. And if it's in the middle of the night, you know what? If it's in the middle of the night and it's becoming a real issue, you're having a hard time, notify your shift commander right away. Adam and I take turns being on call. I know, and I'll speak for myself, I'm not going to speak for Adam, but if there's something that you're having a problem with in the middle of the night, have them page us, and I'll call down to the pharmacy or the ER right away and see what I can do from afar as far as speeding things up. But use that only in case, you know, I mean, you're really stuck there and you can't get on your way. So, all right? So, we got this is October's, and then we got one more, and then we're off for the winter months, off December and January. At the end of CE today, I'll be giving you a survey form. One, you can rate how I've been doing for you guys, and two, what you guys would like to see in CE for next year. On the 28th of November, we are going to have our educators meeting where we will be putting the schedule for next year together. Any of you put down mass casualty and I will hunt you down like a rabid dog. All right? No. You really want it, that's fine. It is what it is. But not only that, if you think of something after I leave today, let Chief Pollitt know because he will be at that meeting also, and then we can get it in. I'd really like us to start seeing, I've been hearing a lot of comments, you know, stop teaching out of the paramedic textbooks. So that's a good one, brain injuries. We're also working, we had a pretty productive chief meeting the other day, chief medical officer meeting, and we had some really great comments that came up. I don't know how many of you guys know NIPSA and Teleflex have been doing a innovation IO lab. We're actually going to see what we can do about trying to bring some of that to St. Francis. Now I know that most of you guys do CE, but we'll kind of leave it open for those that would like to attend, and I'm sure that it's not going to be something that's paid or anything like that, but just something different to offer for you. I'd like to offer this next year too the advanced 12 lead class, just understanding a little bit more about 12 leads. And so we had a lot of good ideas, and so your thoughts too are going to be important as far as what you'd like to see come to St. Francis as far as CE or even additional classes. So, all right, well, we're going to start off by playing Jeopardy today. I think what we're going to do is a little different here. We'll just divide the room up in half. What we'll do is we'll start with one side. You get to pick your category. You get a chance to answer it. If you don't answer it correctly, you get the points taken away, and then the other side will get a chance to steal. And then they can gain the points. Or they can pass if they're not sure of the answer. Okay? I hope we end up with a score better than 10 from negative 40, I think was the last score. So, yeah. Credit this month goes to Ryan Squared, Ryan Banks, who is a captain on Winnetka, and Ryan Menzies, who's a battalion chief on Wilmette. So they are the ones that put this together this month. Okay?
Make sure we vote.
All right, so I'll let you guys start on this side since you've got fewer people, fewer minds. Where would you guys like to start?
Drugs for 10.
Drugs for 10. Okay.
There's volcano on that too.
All right. These two drugs make up the duodev treatment.
Oh, come on.
It's only 10 points, eh?
What is albuterol? Blue purple.
That is correct. What is it albuterol, and Atrovent.
Resolutely proud.
FTNY albuterol.
Take a stretch of line, screw the two of them.
Okay, go ahead over here. Where would you like to try?
Oh, we'll just go P's for 50. No,
All right. Peas for 50.
Okay.
This dose of epinephrine, 1 to 10,000, is appropriate for a pediatric patient weighing 44 pounds in asystole following an IV. I want the amount that you're giving. The amount that you are giving. Yes, the amount that you are giving.
0.44. 24. Baby's working.
Do you have a consensus over here? That is incorrect. That is incorrect. Do you guys want to try and steal?
I don't want to go there, you might put this one.
Oh, yeah.
You can either pass or you can attempt your 50, either one.
Guys, point two.
We'll steal it.
Point two.
Okay, Bill.
Point two.
Is that your answer?
Point two.
Point 2 is correct. You didn't change it to milligrams.
Kilograms.
You did. All right, you guys.
Speak up next time, okay?
Respiratory for 40.
Respiratory for 40. This substance produced in the lungs prevents alveoli from collapsing and allows gas exchange to take
What
place.
is your pick?
That is correct, yes.
Oh, smart guy.
Everyone's like, oh, that's so easy.
Okay,
Keep going, Billy.
No, Jay.
what are you guys doing over there?
I thought we keep going.
I go 50, I think.
No, we're rotating back and forth. I'm sorry.
Cardiac 50.
Respiratory for 50?
Oh, there we go.
At this percentage range of measured carbon monoxide, you can expect a patient to present with the following: severe headache, vomiting, vertigo, and altered LOC. I think they went in the protocol book and found one little sentence, to be honest with you, on this one. Percentage. Not parts per million, but percentage.
What is it, Dennis?
Oh, I don't know. Where's all the preceptors?
I'll be honest with you, I didn't even know this one when they, I'm like, what?
12 to 15.
What is called that?
That is incorrect. 12 to 15 is incorrect.
Incorrect. What is medical control? You said incorrect?
Incorrect.
12 to 15 was wrong.
Yes, 12, do you want to try and steal or do you want to pass?
Are you afraid?
What are you guys afraid of?
Pass? Okay. It is 30 to 39%.
Don't feel bad about that one.
No. All right, go ahead, over here.
Oh,
okay. We'll do cardiac for 50.
Cardiac for 50. ST elevation in leads V1 and V2 would indicate this.
I know you don't.
Septal is correct, yes.
That was 50.
That was 50, yes.
Put 50. 1 V2. Really? 2, 3, yeah.
All right.
Are we winning?
You were at negative 90.
Let's go for 100.
Let's go 140.
I'm sorry, what for 50?
Trauma.
Trauma for 50.
Get him out of the way, that's right.
You know what we're missing Jeff.
These 4 anticoagulants need to be considered in patients involved in a trauma. I actually had to look this one up too.
Serious.
Remember, anticoagulants.
What's that new one that they're giving?
We got 3 out of 4, it's pretty good, I think.
Can you change that question to like 2 out of 4?
He's got the right path, so he's got 3 out of 4. And he's on the right path for the 4th one.
Yeah. Warfare.
Yeah, don't say it.
Warfarin, okay.
Warfare.
Aspirin. Why not have it?
Warfarin and Coumadin are the same.
Oopsie.
Oh, so now we're down.
Okay, Coumadin 2.
You never said we could.
What's up?
What's up, Doc?
We only have 1.
Yeah,
1 out of 4 is what we got. All right, real bad, we filmed.
All right, do you guys know all 4?
Jacobs probably knows. Coumadin, aspirin.
She said no answer.
Oh.
Nope. Coumadin, Predax, Eliquis, and Xarelto. Yeah, like you know those, right?
I didn't know anyway.
All right, go ahead over here.
So.
Commercial show.
Yeah, the commercial one.
Medical control.
Number 140.
What you going with?
No, sorry.
Yeah, it's your turn.
Cardiac for 40.
Cardiac for
It's
40.
gonna be easy to spot watch.
This calcium channel blocker is used in stable SVT or A flutter.
I swear, Bailey.
Dan, Bailey. Dan.
What is the rest now?
Dan.
Baracnil is correct, yes.
Okay, bro time. I'm not gonna do that Armageddon workout.
All right, over here. What are you gonna pick? Oh, probably should see the screen, huh? Drugs for 50 is left. All right, drugs for 50. Given a scenario involving a 2-year-old child presenting with croup in which ebuterol treatments have been ineffective, this is the next treatment per the Region 10 protocol. Buterol's not working on this croupy kid.
Doesn't ask much.
What are you going to do next?
Bailey, you got it?
Nebulized epi.
Yes, that is correct. Woo!
Go.
We're back.
See ya.
1 to 1.
You're down to a negative 90.
Yeah.
All right, this side over here.
Shift 3 fires on.
Leave the 40s. Leave the 40s.
Channel line for
Ambulance 22, engine 23. Transfer McDaniel is person who is fainted in the basement. Use the rear entrance to the basement for person that fainted.
Oh, look at this one. Oh.
I was going to say all the ambulance personnel are gone now, aren't they?
I don't know.
All right, what are you picking here?
Kicking him out of the station, he doesn't get it.
Trauma for 40.
Trauma for 40. This is where you would transport a trauma patient that has been ejected from an automobile and presents with a closed femur fracture and 10% body surface area surface
Oh my
burns.
gosh.
Remember the protocol.
Jack one. Right? Ejected.
That was Jim
Not
said.
restrained, it's ejected. We want to go home here.
I'll take it.
Let's go, guys. Come on.
Closest trauma center within 25
Keep your
minutes.
trap shut over there. That's your final answer.
Yeah, closest trauma center is correct, yes.
Oh, that's true.
It's not the highest level trauma center within 25 minutes, it's the closest trauma center.
Yes.
Yeah, I like them better, what can I say?
Take that. Filthy animal. Kind of runs
All right, go
How's
ahead.
that for being real?
All right, go ahead.
Where are we going?
Drugs for 40? Drugs for 40.
Drugs for 40. What two drugs are contraindicated with ST elevation and leads 2, 3, and AVF?
Nitro morphine.
That is correct, yes.
Bam!
You are on your way to becoming a
Awesome,
positive
he volunteered
number.
himself for a criminal spot, it looks like.
All
You
right,
haven't done it too, bro, we'll put you on it right now.
all right, this side.
Whoa. 48 for 30. Who's
Cardiac for 30. A stable adult in acute coronary syndrome may be given nitro up to a max of how many dosages?
3 doses.
3 is correct, yes. All right, over here. Speeds for 40. You would begin chest compressions when resuscitating a newborn or neonate when the pulse falls below this.
60.
60 is correct.
What is 60?
You are down to a negative 10. Woo! Okay, over here.
Like the dog.
Drugs for 30.
Drugs for 30. These drugs can be delivered via the MAD device. Need all 4.
Like you know this today, you didn't know last thing what we needed.
Wow. Glucagon, Lucid, Narcan, fentanyl.
Very good.
Good.
Just trying to put pressure on you.
That's the one I knew.
General.
Access to the EMS assignment. An engine 21 and a mutual aid ambulance. A 1932 Emerson, adult male experiencing value withdrawal.
Oh, no.
1932 Emerson, 1932 Emerson, adult male experiencing value withdrawal.
I'll make sure. Yeah.
He's sending her with that.
So you give them
No,
it's a couple.
He's in a meeting. Relax. Special meeting.
By the way, were you guys lost this morning?
Kind of. Does it look like it?
No. You had stopped on Dempster and then 2 minutes later you got all dressed up and then 2 minutes later you're heading back down the road again.
They're canceled.
Oh, yeah.
The lights and sirens both times?
Canceled.
Run when you get there.
You guys cleared for us.
Unless you get guys like Lynch who drive.
Because,
He just
yeah,
waits until
truck
you get to
20,
the general
yeah,
large
23 went en route, then we took it, and then they stopped, and then they went back en route, and then they canceled.
Would be the first time.
You have to make sure it's
Yes, it is your turn.
Let's do respiratory.
Respiratory for 30. Common in cases of croup and other upper airway obstructions, this breath sound is characterized by high-pitched sound, heard on inspiration. Yes, Strider is correct. And for the first time in this game, you guys are positive.
We were negative 190. We're back. We're good. We're back to 0.
All right, this side over here.
We're good. We're back. You guys, pick up the slack.
Hey, you guys put
Cardiac for 20.
Cardiac for 20. Name this strip.
Ooh, that's a good one.
Oh, come on.
There it is. I know what it's
Yeah, I didn't say that.
No, it's 3.
SVT. Don't tell him. Yep.
It's SVT.
It's,
That it is.
Hey, there's one fine.
You got it right.
What is Winky Bar?
That is correct, yes.
What height? Small bits, bitches.
See the hyphenated right there, bro, bitches?
All right, over here.
Sorry, Chef, wanted to.
Dan Bevan.
Never would have guessed.
What do you want to pick over here?
Oh, pick one?
Yep, your turn.
Let's go. Trauma for 30?
Trauma for 30. A 13-kilo child requiring a fluid resuscitation will receive an initial bolus of how much saline? So how many mLs are you going to give this patient?
20 per?
That's
So it's 260? Yeah, but I think you stack it.
You stack it to max load.
Do you?
Reassess at 200. Initial bolus. You reassess at 200.
So how much you giving this patient?
Right? 260.
260?
Initial bolus.
260 is correct. Now, you guys made a comment, I just want to take a second here. You said you stop at 200. In the adult, or for every medication, we never exceed the adult dose. However, the dose is 20 mLs per kilo for everybody. Adults, we do reassess at 200 because usually their hearts are not as strong, they're more likely to go into fluid overload. Children, their hearts are healthy, we're not worried about their lungs, so you could give a child the full 260. We never exceed 60 mLs per kilo for a child though on the initial bolus. Or total boluses, I'm sorry. All right, this side over here.
We're beating them now, right?
Yes, you got that one, yes.
Drugs for 20.
Drugs for 20. This is the minimum and maximum dosages of dopamine in mics.
What is 5 to 20 micrograms?
5 to 20 is correct.
We do calculation.
You don't want to?
I can drop the zero.
Over there, what would you like now?
Sure. Beats for 30.
Peds for 30. This is the initial amount of normal saline given in a pediatric fluid challenge. If you get this one wrong, we have a problem.
20 per.
Very good.
For what? Hello.
For your mother.
We'll see fight later too. Hello.
Station to the members.
All right, over here.
All right, so then,
Trauma for 20. In order to calculate the percentage of a body surface involved in a patient who has been burned, what method do we use?
Rule 29. What is rule 9?
Hand method.
What is what?
Rule 9.
Very good. All right, over there.
Sure. Respiratory.
Respiratory for 20. Ooh, a pediatric patient with an obstructed airway requiring a cricothyrotomy would need to weigh at least this in order for the quick trait to be used.
20 kilos.
No.
Oh.
I was pulling for you. Do you guys want to try stealing?
This is not a 20, no, it's a 50.
This is more.
no, I bet you.
What's your answer? Are you going to pass or are you going to go for it?
Just go
Yes,
for it.
go for
Just- yeah, we're going for it.
What's the, what are the points?
Want to go home, remember that.
The points are 60 to 350.
Right. 10 kilos?
10 kilos is correct, or 22 pounds.
Big brain.
20 was
All right, which one would you like to choose over here?
Respiratory. Respiratory.
Respiratory for 10. This King Air airway would be used on a patient that is 66 inches and weighs 82 kilos. I need a size or a color.
5 or 6, 4 or 5, 6, whatever that means.
He's in the 5-foot areas.
4.
4 is correct, yes.
Is 4 red or red?
All right, over here.
Well, I don't think we're gonna come back.
Listen to that conversation.
Take them all for.
3, 4 is fine.
We'll get them
You want?
Sure.
Beach for 20.
This is the number of millimeters of mercury you would set your meconium aspirator at for suctioning. 80 is correct. Okay. Choose one. Cardiac for 10. Tell me, diagnose this 12 lead. Tell me what wall is affected here.
2 and 3. Jake, you read these things in the hospital, just do it.
All right, so,
I put them forward.
what is inferior wall?
Very good. You on trauma or peds over there? Trauma. In a traumatic arrest, patients with associated chest trauma, this procedure is indicated bilaterally.
Needle decompression.
That is correct. And the last one for you guys, pediatrics. Under what age is a patient considered a pediatric patient?
6.
That is also correct. So, the end score, we have 90 over there to 400.
Not bad.
Not bad. No final Jeopardy.
You guys let me down. We have to test this.
God will get us wrong. God will get us.
All right, this month is Skills Month for CE. And so Chief Collop will be sending out skill forms for you guys to go ahead and do on your leisure at the stations, okay? He'll have some verification forms, so he'll work that out. So get with him on that. But before we actually put you out there to do it, we're going to go ahead and review some of these skills, and then we're done for the day. So it's not too long. There's, I think, 7 skills that we're going to briefly review. So we'll start off with hair traction splinting. What patients get a hair traction? Open or closed?
Close.
All right, closed femur. In general, per our protocols, it is a closed femur fracture. But there is something I want you guys to know. You may be told to put a traction splint on someone with an open femur fracture, depending on how you describe it. International Trauma Life Support and Pre-Hospital Trauma Life Support both now recommend, in some cases, open femur fractures being used. But why do we use a traction splint? What's the purpose of it? Okay, does it restore circulation? But bottom line is, see here, we want to go ahead and we want to straighten it out a little bit. Mainly so that we don't have the edges of those bones destroying muscle, blood vessels, or nerves, okay? Now, we know that femur fractures can be caused all different sorts of ways. We've got twisting mechanisms, and we have the direct blow. Take the time to put these on in the field if you can. About 3 to 4 times a month at our hospital when patients are brought in, they may have a femur fracture, but it is not put on in the field. You know, take the time because it's going to be a lot better for the patient, especially if you guys are, you know, bouncing down these lovely roads that you guys have here in Evanston, because it does protect the patient. Also, remember, a lot of blood flow can be in that thigh area without you even realizing it. about 1,500 cc's. This here is from a twisting mechanism, and there's the x-ray on that, okay? Yeah, they had to have surgery. So, it's sometimes hard, and we hear a lot of people say, well, I don't know if there's a femur fracture. I don't have x-ray vision. And that's true, you don't. If you suspect it, you know, one, you have a decrease in pedal pulses, or you see the deformity in the upper thigh, that's always an indication. Major swelling in the upper thigh. The big thing though is look for signs and symptoms of shock. Now remember, if we lose about 1,500 cc's of blood into that thigh, the patient is probably still compensating. And what do we see with compensating shock? We start to see heart rate go up, anywhere from 100 to 120. But vital signs stay pretty consistent. We're not seeing a drop in blood pressure at this point in time. Maybe a little bit of an increase in respiratory rate. As we get up near 2,000 cc's into that thigh area, now our heart rate is probably between 120 and 140, and we're going to start to see a drop in blood pressure. At this point in time, they're decompensating. We can still do something to go ahead and help them, but we need to act quickly when we're working with these patients. And then finally, when blood pressure really takes a plummet, goes up over 140, don't confuse that with SVT, all right? But know that the patient has gone irreversible. When the heart rate gets so high, the blood pressure gets so low, you're going to start to see all vital signs go ahead and decrease. And by that time, it's too late. There's nothing we can generally do for these patients. Make sure that, too, you're not using a hair traction splint on someone who has a hip fracture. You know, don't confuse the two. So, I'm going to go right over to here. We have this, you guys use the hair traction, right? You don't use the Sager or the Kendrick. A lot of places are switching to the Kendrick because it comes in a little bag like this. It's got the 10 pull stakes. I don't think it's as good as what the hair traction is here, but a lot of them do it to save space on the ambulance. So to start off with, you've got the hair traction, you've got it out of the bag, you've dusted off the dust on it, and you're ready to go ahead and use it. Where do we start? What's the first thing we're going to do? Yeah, we're going to go ahead and have someone hold manual traction on the affected leg and measure on the side of the good leg. Now, how far down do we want this end to be? Past the good leg. How many inches do you think? A lot of people say about 6, but I'll be honest with you, even go a little bit further. 8 to 10 inches is probably pretty good. I see it, we had one in the ER that they only put it at 6 inches, and what had happened was they actually had to regain manual traction and undo everything and then pull it out to make it even longer because the patient, it wasn't providing good traction yet for the patient. So, and that caused more harm. So we'll go ahead, once we get everything measured, we've got everything in place, we're going to go ahead and slide this end underneath the ischial tuberosity. Put that in place, put the groin strap on, make sure that's secured. While someone is still maintaining manual traction, we'll go ahead and put the ankle strap on, and then we'll hook it on the hook. And we'll start to apply traction for that leg. When do we stop? How do we know that we have gone far enough?
Relief.
Yeah, relief. Now a lot of people, they're not going to say, oh, all of a sudden that feels a lot better. That's not what's going to happen. Originally, your patient is going to be in a lot of pain, probably screaming out. When the screams start to get a little bit less and the patient isn't in as much pain, we know we've met our objective. Plus, we've had the return of a pedal pulse. We've got good sensory motor. Okay, cap refill is another thing you can check. At that point in time, once we end up with good return of circulation, we're going to go ahead and put the Velcro straps over. Remember, we don't put a Velcro strap over the knee, and we don't put a Velcro strap directly over the injury itself. And all this says is exactly what I said. Now, one thing to remember, do not forget to check your CMS before you put this on and after you put this on, okay? Always go ahead and re-verify that constantly. Every 5 minutes that should be checked, or anytime you move that patient. So once we got the patient with the hair traction splint in place, how are we getting them from the floor to the ambulance? Yeah, you can put them on a backboard. It makes for moving them a lot easier. However, once you get them to the cot, it's easier to move them over to the, off the backboard onto the cot directly. Now, do you guys have quite a bit of room between the end of the cot and the doors in your ambulances? Sometimes you do, sometimes you don't. It just depends on what kind of ambulance. Remember, if you watch that end so you don't shut the door on it, and if it is too long, you can move the patient up, or you can turn the patient around backwards. Remember, not the cot, put the patient on the cot backwards. Always make sure you're monitoring for shock, looking for those vital signs. This is a critical patient, so we're going to be monitoring vital signs every 5 minutes. Checking CMS or doing a neuro check every 5 minutes. Anybody have any questions on using the hair traction? Pretty straightforward. Biggest thing is making sure that you are using them in the field. It's going to be in the best interest for your patients. All right, the next skill is slings. From what I understand, you guys actually have real slings in your ambulances, not just the triangular bandages. All right, very fortunate. Because honestly, watching people, even brand new EMT basics, trying to figure out how to put the triangular bandage on is pretty comical. So let's start off with the forearm and the wrist. What is the best way to go ahead and splint the forearm or a wrist injury? Sand splint, yeah, that's really actually a very good one. You got the board splints, put a piece of gauze in their hand, put the board, you know, whichever way is most comfortable. What we have to remember with a lot of these patients, if they've got that forearm or wrist injury, they're going to be splinting it themselves. They're going to have it in the position that is most comfortable for themselves. And so jarring it around, moving it around, obviously is not sometimes in the best interest. Again, and I forgot to mention this with the hair traction, one thing that you make sure that you always do, give them a little bit of pain medicine before you start manipulating, before you start moving them, okay? Don't have to start an IV on the patient. You can go ahead and use the fentanyl via the MAN device. And I know it doesn't work as well as what an IV fentanyl does, but at least to start, to get them to the ambulance, to get them moved. Give them the fentanyl. Once you get in the ambulance, then if you want to start an IV and you want to give it via IV, that's perfectly fine. Remember your basic skills for splinting, or for any type of fracture or injuries. Position of comfort, an ice pack, and a splint is going to go ahead and reduce a lot of the pain in itself. Now, what's nice about using a triangular bandage or even a sling at that point in time,
Engine 22, mutual aid ambulance. Fire station number 2, 702 Madison, just outside. The stick that's been battered in the head. The offender is no longer on the scene. EMS assignment, engine 22 and a mutual aid ambulance going to 702 Madison, outside of fire station number 2. Suspect was battered in the head. The offender fled the scene. On page 72, 948.
by going ahead and splinting this, and even if you use a regular splint that you have on the ambulance, you can go ahead and use the swab to wrap around the patient. That's going to go ahead and prevent it from being jostled around. If you go back to putting this on, if you have the patient sitting on the cot, maybe even take a pillow and let them rest it on that pillow. That will be sometimes pretty helpful. Again, it's really important that you're checking your CMS before and after splinting. Okay? Make sure that if you are using the splints that it's not pulling on the neck. Sometimes even going ahead and putting a towel behind the neck before you go ahead and tie it or attach the sling will give the patient a little bit more comfort. If it's a collarbone or a shoulder, generally you're going to see the shoulder drooping If it's collarbone, you might see that little knot right along the collarbone itself. Hospitals now are actually putting them in splints. If it's a collarbone, they're going to pull the shoulders back. So if the collarbone is originally like this, by pulling the shoulder bone or the shoulders back, it will go ahead and hopefully align up the two bones so they don't end up having to have surgery. Generally, unless they've really done a number on it, most don't end up having surgery. We go ahead and do things a little bit differently if it's a collarbone or a shoulder. You're going to go ahead, this one is going to go underneath the arm on the front side, and the back one's going to go up so that you end up tying it right at the upper shoulder blade area. And then you can go ahead and wrap the cloth around it, around the body. That will help keep it in place and prevent any jostling around. Anybody have any questions on splinting? Okay, I'm going to give you guys an opportunity to watch a really cheesy video here.
My name is Adam Gallegos. I'm a firefighter paramedic with the Castle Rock Fire and Rescue Department. Today we're going to be going over the intermuscular medication administration scenario. First, BSI, gloves and eyewear. You can also verbalize this during the scenario. First thing we want to do is ask the patient about any allergies to medications and any adverse reactions to medications that they may have had in the past. We're going to explain the procedure, explain what we're going to be doing, and then we're going to prep our equipment. We're going to check and recheck which medication we're going to give the patient. We're going to observe the clarity, look at the expiration date, make sure that it's not expired. We're going to make sure it's the right patient, the right medication, the right dose, the right route, and the right time. So now we can drop the medication. Keeping things sterile, we're going to clean the top of the vial, insert the syringe, drop our correct dose. Once we've got it drawn up, we'll expel any air out of the syringe. And now we're ready to administer it to the patient. Now that we have the medication drawn up, we need to choose a site to administer the medication into. We have three options: the deltoid muscle, the lateral thigh, or the gluteal muscles. Now we can administer the medication. First off, we want to cleanse the site. We've chosen the deltoid here with Jody. We're going to cleanse the site with an alcohol prep. Pinch the skin slightly to lift the skin. For this, I'm going to simulate with this other syringe, actually administering the medication on Jody here. We're going to insert the needle at a 90-degree angle with a nice smooth motion. We're going to aspirate slightly, which means pull back on the syringe looking for any blood return. If you get blood return, you need to remove the needle immediately, control the bleeding, and pick a new site. Once we know that we have no blood return, we're not in any arteries or veins, we're going to depress the plunger, administering the medication. We'll now remove the needle. We're going to dispose the needle into a sharps container, and we'll document the dose and the time that we gave the medication. Now that that's done, it's important that we monitor the patient for a couple of different things. We're going to monitor the site for any signs of swelling.
Okay, a couple things about IM injections. First of all, what is our general location that we use? We use the deltoid, right? There's only a couple instances why we would use a lateral thigh. One would be an EpiPen. Second of all, very important that you guys, when you draw up your medication, use the 18 gauge needle, but it's really important that you change the needles in between drawing it up and administering it. First of all, what size needle should we use if we are administering an IM injection? Try a 25, 27 gauge, at least the inch and a half is what you're really looking for. Do not use an 18 gauge needle to give an IM injection. You'll probably get hit if you do so. Pretty painful. But use the 18 to draw it up, change your needle, use the 25 or 27 gauge needle 1.5 inches to go ahead and administer it. Now, one thing that we're seeing that not as many people are doing anymore, and that is they're not Z-track. You know, they showed where they went ahead and they grabbed the muscle, pinched it, and then went ahead and inserted the needle. If you start off by going ahead and inserting the needle into the muscle here itself, and then you pull it out, you've created a straight pathway for any medication that you put in to come right back out that same injection site. So as you go ahead and grab the area, pull over to one side with that top muscle. So that way when you go ahead, you put it in, you're going to end up with your pocket, but then when you let it go, the top of the skin will kind of slide back where it was, and it's not going to be a straight shot out for the medication to come out. Do you ever watch your, did you guys get flu shots this year? Did they do that for you? They don't do that for you?
Yeah, they did.
Oh, okay. You know, and sometimes some of those nurses, you know, they don't do that, and if you watch, you'll see a couple drops of the flu shot or medication come out. So what medications do we give IM injection per our system? Well, we got Benadryl, right? Epi, 1 to 1,000. Valium, Versed. Yeah. Different ones that we can go ahead and administer. So with our allergic reaction, we can give the Benadryl 25 milligrams or 50 milligrams, depending on which protocol we're working on. Can be given IM, IV, IO. We give Epi 1 to 1,000 in our anaphylaxis, 0.5 milligrams. We give that IM. Behavioral, we can give Valium as an IM injection also. And then seizures, we give Versed. Now we can give it IM, but we try and give it IN just because we don't want to be messing with the needle anybody around that's season. And then finally we have the glucagon. Glucagon is given IM also, or can be given IN. We have the duodotes. So, do you guys know where your duodotes are? I just love this. Remember, I think it was back in 2000, well I know in 2010, all of your Mark I kits went expired. And so the government issued duodotes, which is the 2-PAM and the atropine for any nerve agent. That's fine. The problem is, they're all sitting in your hazmat truck away. So if you ever end up needing them, you're going to be dead by the time they get to you, just so you know. I don't know why they're not in the stations. I've been trying to find this out for almost 4 years now, and no one's given me any direct answers. So I don't know what to tell you as far as the duodotes. They should be on your ambulance, but. Okay, sub-Q. Watch a nice little video again.
Hello, I'm Amber Darn. I'm one of the pharmacists here at Leesburg Pharmacy. And today I'm going to show you how to administer a sub-Q administration, which is subcutaneous or under the skin. As you know, we have other videos, one of which will show you how to withdraw the contents of your medication into a syringe. So this is assuming you've got everything all prepared, ready for your injection. The supplies you make sure you have on hand is an alcohol swab. You would also have a Band-Aid, possibly a cotton ball or a 2x2 gauze, just in case you might need it, as well as the dose that you've prepared for the injection. Keeping in mind that the syringe, the needle length, as well as the appearance, color, consistency of the dose that you've prepared may look different from the one that I'm using for today. So we have Sherry with us today, and she's going to be getting a sub-Q administration of a B12 shot. So some of the sites of locations where you could inject it would be the back of the arm. You could also do your abdomen, around your belly button area. On the lateral side of your thigh would be another area if you're self-administering. Obviously, I'm showing you how to do the injection today, me administering onto another patient, so it is a little bit different. But keep in mind that there are some other areas that you can inject the dose. So we'll have her just have her sleeve rolled up, and we are going to inject in the back side of her arm here. So typically in the area around this area, okay? The idea is that you do not want to get into the muscle. So when in doubt, you can always just kind of look at the muscle, which is usually the deltoid muscle here, and you would want to inject in the area right below that on the back side of the arm. So to prepare for the injection, where you think you may inject, you're going to start at that center point and you're going to swirl around when you're swabbing the area. So that's taking any dirt or bacteria away from the site of the injection. I have my cotton ball ready, for those of you that would be using that. And I'm going to have my syringe ready, taking the cap off very quickly, pulling the cap away from me so I don't prick myself with that needle. And then just kind of hold it like a pencil, and you're going to have it, your hands pinched around the area that you're going to inject, and you're going to hold the needle at a 45-degree angle, and you're going to insert the needle, and then just slowly inject the medication. By doing it slowly, it doesn't cause as much pain for the patient. And then you'll put your syringe into a sharps container if you have that on hand at home. Just hold the cotton ball at the area there. Typically for a sub-Q injection, you don't see any bleeding, but just in case, you want to have that cotton ball ready. And then you can place the Band-Aid in the area if you wanted to put the Band-Aid there. And then that's it. That's the sub-Q administration.
All right, sub-Qs. You're looking at about a 1/2-inch needle. Usually they're about, again, anything from 22 to 27 gauge needles for sub-Q. The area we mostly use is the back of the arm. That's a good fatty area. Very seldom do we ever use the abdominal area for administering. Now, currently we use the sub-Q for the 0.3 Epi 1/1000 in the allergic reaction protocol. I will tell you that coming up with the new ones, we're getting rid of doing sub-Qs. We're finding, obviously, they're not as effective, and there's no point. That's really the only one that we go ahead and use. Anybody have any questions as far as IM sub-Q injections? Okay, innovation. When's the last time anybody has innovated in this room? Been a while? Anybody longer than a year for innovation? Couple of years, yeah. I'll be very honest with you. I hate the way our protocol is written. And fine, I'm recording it. That's good. Someone will hear this. Our protocol states, especially under drug-assisted innovation, attempt innovation ×2. If unsuccessful, move on to the King Airway. Here's the thing about innovation. We don't do it very often. And, you know, it's a big topic right now about should we take innovations away from paramedics. I don't believe we should, because there's definitely times like burns, anaphylaxis, or asthma that we need that innovation. But we have to be allowed to think for ourselves, know our own skill set in order to innovate. I know that I haven't innovated probably in about 1.5 years, and never very good at it to begin with, to be honest with you. I know that if I look at an airway, I'm going to take a look and I'm going to see how difficult is this airway before I even start. I use the Mallampati score. I know a lot of you are looking at me like, what the heck is that? But it's looking in the mouth. Can I see the hard palate, the soft palate, the uvula? If I can see all three, pretty easy innovation. But if I can't see anything, we call that a class 4, means that it's very difficult. If I see someone that's not a class 1, because I know my skill set, I'm not even going to attempt innovation. I'm going straight to that king. Because no airway, no patient. The longer we futz around with trying to get a tube in this patient, the more the brain becomes anoxic. And that's going to be not beneficial for our patient. So, as far as I'm concerned, be that really great medic. Realize your limitations. Know what you can do and what you can't do. And do, based on the patient's presentation, what's best for the patient. Okay, we'll just start with that. Now, when we innovate, we obviously need to have proper blades. Everybody has their own blade that they're comfortable with, I guess. You know, when you went through paramedic school, you probably had an anesthesiologist that said, you are only going to use a Miller blade, nothing else. You don't know how to innovate unless you're using this. You know what? It's what you're comfortable with. So we have the Miller blade and the Macintosh. Macintosh is curved like a Macintosh apple. Miller blade is straight like a can of Miller beer. They each go a little bit different. The Macintosh is going to fit right in the vallecula, right where this one is, and it's going to pull the epiglottis up out of the way. The miller is going to go ahead and sweep the epiglottis away and open up so you can go ahead